The next step in the eye exam is to check pupillary function. And unlike when you check patients' vision with a very brightly lit room, what you want to now do is check the pupil response and check pupils in a very dimly lit room. So as best as you can in your clinic or at bedside, you want to try to lower the lights as best as you can. The other thing to remember is that when you're checking pupils, you should ask the patient to look and fixate at a distant target. It's not good enough just to ask them to look out at a distance, but actually ask them to look at something maybe on the wall, maybe the clock or something like that, so they maintain fixation at all times. Because if they start to look up close and they start looking at your instruments or your face, what will happen is the pupils will constrict and you will not be able to get a very good pupillary examination. So the first step in the pupillary examination is to just do an external inspection. What I like to do is to look to see if the pupil is regular in shape, if it's round, if it's irregular. You may want to ask the patient if they've had any intraocular surgery, maybe trauma, maybe they've had a congenital abnormality. And that might help explain why the pupil is irregular. There are certain infections also that can cause an irregular pupil. So a history is very important when you detect an irregular pupil. Once you've looked and determined that the pupils are round, the next step is to look at the size of the pupil. And you're looking to see if the two pupil sizes are equal between the two eyes. Now remember that 20% of patients, the normal population, has unequal pupil sizes. So very often I see people, and I've done it myself, write PERLA, as I think everybody has done, which is pupils are equal, round, react to light and accommodation. Well, if you're writing PERLA very often, 100% of the time for example, then you're probably not doing a very good eye exam because 20% of people will have unequal pupils, which is the normal size difference that you will see, about 1 millimeter or so. So once you've determined that there is no anisocoria or there is anisocoria, the next step is to check the light reflex. So by convention, what I like to use is I like to use a pen light, for example, a pen light, or in this case, I have a muscle light. We have this available in the eye clinic, but if you don't have this, you can use a very strong pen light. And again, what you'll remind the patient, as I'm going to remind Jackie, is to look at a distant target. And what I'll do is introduce the light into one eye. And as I introduce the light, I'm looking to see what kind of reaction the pupil will show. I'm looking to see if there's a sluggish reaction or a brisk reaction, and there may not be any reaction at all to light. If you see no reaction to light, then the next step is to ask the patient to accommodate and look up close. Maybe with using their thumb, for example, have them look, and you are looking to see if the pupil constricts. Now, you only do this if there is no light reaction. Thank you very much, Jackie. If you see a light reaction, you don't need to check accommodation because in almost every case, if the pupil responds to light, it will respond to accommodation. If the pupil doesn't respond to light but it responds to accommodation, then we have what's called a light near pupil dissociation, and there's a whole differential diagnosis that we will talk about later on in this video. So again, we'll have Jackie look at a distance, and I will then shine a light into her eye, looking again to see what kind of direct light response I have. At the same time as I'm doing this, I'll also look at her opposite eye to look for a consensual light reaction, because remember, as the light goes into the eye and then goes into the midbrain, it'll send the exit innervation to both pupils, so both pupils should react simultaneously. Once I've done that for the right eye, I'll then go over to the left eye, and again I'll look at the direct response to make sure that the pupil responds briskly, maybe sluggishly, maybe not at all. And I'll also be looking at the consensual response as well as I shine the light into the left eye. Once you've determined the direct and consensual response of the light, the next step, which is a very important step, is a swinging flashlight test. And the swinging flashlight test will indicate whether a patient has a Marcus gun pupil or a relative afferent pupillary defect. A Marcus gun pupil is very often seen in optic neuropathies, for example, in optic neuritis. So it's very important that you do this part of the examination. And again, you want to ask the patient to look at a distant target. You'll shine the light into one eye, and then you'll go quickly over to the other eye, and you'll go back and forth, just swinging the flashlight back and forth between the two eyes. And normally what you see is that the pupil will constrict or will remain the same size as you go back and forth. But in a Marcus gun pupil or a relative afferent pupillary defect, the pupil, as you shine the light into that eye, will actually paradoxically dilate. So you'll see actually a dilation of the pupil when in fact the pupil should be constricting, and that is a sign of a relative afferent pupillary defect or a Marcus Gunn pupil.